definitely make an announcement. Okay, put this. All right, good morning. Okay, so I've had several questions through email and now in person here this morning. So the bonus 3 points, which is the donation, it's supposed to be something that's cheap, not expensive because you're college students and you're poor. I have boxes outside the main biology office, chemistry office, outside the writing center, English department, housing office, outside the inner entrance to the library. I feel like I'm missing something, but the closest one is right outside the main biology office. Okay, and it's honor system. If you donate something, you just email me and I'll keep track of it. I've got an email folder for that, and I've been trying to update when people have made a donation. I try and post it at least every couple of days. All right, so if you have any questions, just email me. But the closest box is outside biology and outside chemistry, and then some other places on campus. Any question about that? Okay. The other thing I wanted to bring up, I don't need this page now, is where's my syllabus? Okay, let's make that a little bigger. Friday, don't forget about the quiz. All right. It's going to be 25 questions, which is different from the first quiz. I think it was only 15 questions, but that makes each question worth only 2 points. All right. And I'm just going to do Scantron. So bring a pencil. All right. I'll have some, but not enough for the whole class. All right. So remember, that's the remainder of chapter 4. I mean, you can see it right here. Oh, turn this on. All right. So after acetylcholine signaling, so know your epinephrine pathway regulation of body functions and the beta 1, beta 2, and alpha receptors, adrenergic receptors. And then, of course, the other neurotransmitters, dopamine, norepinephrine, serotonin, drugs that affect them, disorders involving them, and then glutamate, glycine, GABA. All right. And the drugs that treat erectile dysfunction, which involves the nitric oxide thing. So that's the remainder of chapter 4, part 1 back there. Okay. But that will be the end of that. But that quiz is coming up Friday, so don't forget about it. Any questions on that? So the end of the semester is coming. All right. Not to freak you guys out, but I told Tuesday's lab, not Monday's lab, but here we are. And then April's coming up. The last day of class, I believe, is the 25th. Let me go back to March. So we have lab next week, which is the kidney lab. And then the week where we start April, we have the last lab of the semester, which is a case study. It's not a PDF online, because when you come into lab, I'll have it printed out and I'll hand it to you. Okay. That's it. It's happening. All right. You're registering for fall classes and all that stuff. So this is meant to encourage you. It kind of freaks me out because it's steamrolling to the end very quickly, but it's also to encourage you. Don't quit the marathon before you cross the finish line. Keep that fire under yourself. Keep pushing yourself. The end will come and then you'll get your break. Okay. So, all right, let me get this out of the way. So we in lab, we're doing blood physiology. Okay, so okay. I think it's trying to record me and I don't want it to. Let me stop that. It's very annoying. There. Unless there's anyone here who's hearing impaired and wants to see the text of what I'm saying on the screen. All right. So we did the blood typing. Okay. And I went over this because there were some questions on the lab quiz this week involving blood typing, what kind of blood you could receive and things like that, but mostly on the blood typing. And the people who did the blood typing lab, it's super easy, right? A couple of minutes of your time. And now you know your blood type. So the people who have had lab this week, you've seen it. You've seen the plastic trays where you put a drop of your blood and then an antibody to either A antigens, B antigens, or Rh antigens. And then you'll see the agglutination reaction where if you have the antigens for a blood type on your red blood cells and you add an antibody against that antigen, the antibody clumps to the antigen, and that's the clumping that you see in a positive reaction. So here's anti-A, anti-B, anti-D is Rh. So some of you saw this, all right? So if you saw a reaction in the A well, that means you have A antigens, that's type A. If you have a reaction in the B well, you have B antigens on your blood, you're type B. If you have a reaction in both wells, let me move this because it's kind of obscuring the screen. That means you're type AB. If you have no reaction in the A or B well, it's type O. And some of us in lab on Tuesday found out why they call it type O. It's a German word for zero, zilch, nothing. And then if you have a reaction in the RH well, it's your blood type A or B or AB or O. And then positive indicates you have the RH antigens. If you have no reaction in the RH well, that makes you negative paired with your ABO system. Very simple. Okay. All right. So the RH factor. So in lab Monday and Tuesday, I did by show of hands, how many people have this blood type, that blood type, whatever. And then I said, regardless of your ABO blood type, how many have the RH antigen? And it's the majority of the class. It's far more common to be RH positive than RH negative. And you all saw that had lab this week. In Wednesday lab, you'll see that. So the RH incompatibility in pregnancy, very common. I think right now, doctors just preemptively treat a woman for the possibility that this could go on. But if they know your blood type during your pregnancy, if they know your husband's blood type or whatever, they can predict there's a 50% possibility that a child could be carrying the RH factor. So here's what happens in RH disease. Let's see if I can get a little laser pointer here. So if a woman is RH negative, and we already know it's more rare to be RH negative. So this is not a huge risk, but it's there. And if she's pregnant and the husband is RH positive, there's a 50% chance the child she's carrying is RH positive. So basic genetics. So if mom doesn't have the RH factor in her blood, on her red blood cells, her immune system has never seen that antigen. The immunity works by, if you're exposed to an antigen you've never been exposed to before, your white blood cells, particularly lymphocytes, will start the reaction of forming antibodies against that antigen to protect you. That process takes bare minimum of 2 weeks, usually 3 weeks. That's why people who get the Pfizer COVID vaccine, they got their second booster in 3 weeks, because it takes about 2-3 weeks for you to have an antibody titer, right? So if you've had that, you know what I'm talking about. If mom's immune system detects RH antigens in the baby's blood in 2 to 3 weeks' time, her immune system will form antibodies against that RH antigen, against those red blood cells carrying the RH antigen. How, might you ask, would a woman's body be exposed to fetal blood? Because mom's bloodstream is separate from baby's bloodstream, because the placenta allows diffusion of things from mom's bloodstream across into the baby's circulatory system. There's no direct communication of blood. However, if she has a difficult birth, okay, if the baby's not in the right position and they do external cephalic version, where they try and reposition the baby in the correct position for birth, which is head down, that can cause breakage of minor blood vessels. If she has a very difficult birth and there's some tearing of fetal membranes, like even just the amniotic sac and all the cells it contains, if there's any blood cells in there and mom has a little tearing, mom's blood could be exposed to baby's blood. A C-section, all right, they cut the woman open, they pull out the fetus, the baby, all right, there's a chance that mom's bloodstream might come in contact with baby's blood cells. And then 2 to 3 weeks later, she forms antibodies against it. And those antibodies could last for a lifetime. It's not a problem for the first RH positive baby she carries, but the next baby she carries that's RH positive, the antibodies are in her bloodstream. Those antibodies can cross the placenta. Those antibodies can cross over in breast milk. They will go after fetal red blood cells and cause them to lyse. So it's not a problem for the mom. It's a problem for the baby, which only has a finite blood supply. So that's the danger. All right, so this is basically what I've explained. Mom's immune system would develop antibodies 2 to 3 weeks after exposure to fetal red blood cells with the RH antigen. Once that happens, it's a done deal. You can't reverse that after it's happened, but you can prevent it from happening. And so what happens, well, first of all, it's called autoimmune hemolytic anemia. Autoimmune, the immune system is going after self. Well, technically it's going after fetal tissue. It's called anemia because it destroys the fetus's red blood cells. And hemolytic, it's destroying or lysing the red blood cells. So that's what's happening. It's also caused by some other things. If I can get, oh, now it wants to use this laser pointer. Okay. You gonna let me hit that? Just give me a sec here. It's trying to do something like either write or use a laser pointer. I guess that was my mistake, trying to use the laser pointer. Just give me a sec. I'll fix that. Bless you. There we go. Now we're back. All right. So it's known by many different things. So that's what I'm trying to do is hit this app because they call it erythrosis, erythroblastosis fetalis, hemolytic disease, and it's also autoimmune hemolytic anemia. So this, I like this because it makes sense. Erythro means red blood cell. Blastosis is basically the red blood cells are being destroyed of the fetus. So it's known by different names. Now, anyone who's had a baby in this class could tell me if this is in fact true. They will preemptively give a woman, especially if they know she's Rh negative, an injection of anti-Rh antibodies. And that's what this is. It's to prevent her immune system from forming antibodies if they suspect there's been mixing of maternal blood and fetal blood. So it's anti-Rh antibodies. You used them in the lab this week. You added anti-Rh antibodies to the well with your blood to see if you had Rh antigens or not. So they produce these antibodies. All right. You can sell them commercially. You can also sell the injection of these antibodies. So what happens is they inject mom with these anti-Rh antibodies. And if there are any fetal blood cells in her system, the antibodies will detect them. They will clump them in agglutination like you saw in lab. And then mom's immune system will destroy all those cells. So before her lymphocytes can form antibodies to it, so destroy those fetal red blood cells in her body before her immune system reacts and forms antibodies. Has anyone ever heard of this whole thing? Give it preventive. Yeah, did they do that with you?
No, because I was born Rh positive.
So they didn't have to worry about it. It's
But they test your blood at your first appointment.
so she said that they test the mom's blood at the first appointment. If she's Rh positive, it's not a concern. Her body has seen the Rh antigens. It's not going to react. If you're Rh negative, though, then the risk of this happens if the baby's Rh positive. But does that make sense? Because it seems almost counterintuitive. You're injecting the mom with anti-Rh antibodies, and that's supposed, it works. Okay, so it's common regularly. Okay, in your handout for the lab, there was the listing of white blood cells. So now we're talking about white blood cells and their reactions. From most frequent to least frequent. This used to be an NCLEX question, nursing NCLEX exam question. I know the NCLEX has changed. I don't know if this is still on it, but it's kind of a classic. So in order from most frequent to least frequent in the bloodstream, all right, this is not necessarily the order, but down here there is. But let's talk about them because we'll be covering the immune system. Did you guys cover the immune system in anatomy at all? Immune organs, so they don't usually, but it's important. It's important. So the most frequent are neutrophils. They're kind of like the EMS of your body. They're going to be first on the scene when there's pathogens that enter your body. They circulate in your bloodstream. They can also cross your, basically your vessel membranes and get into your tissue and wage war. If you've ever had a small infection in your skin, it gets swollen, it gets red and hot. That is white blood cells that have crossed over into the tissue and they're now mounting an immune defense. Neutrophils are the first responders to infection of a pathogen, right? And so they have a nucleus that's segmented. See these little dark things? And they have granules inside them that are kind of pale if you stain them. Now, next most frequent are lymphocytes. Why don't I just cover them in order? Well, the way I've grouped them here is the white blood cells that have granules inside and the ones that don't. So these three have granules. So the next white blood cell kind of infrequent, as people in lab know when they looked at that laminated sheet. Eosinophils, you see with chronic inflammation, long-term, all right? They show up after it's been going on for a while. They're especially important for allergies and parasitic infections. You will see these. Now, they have a segmented nucleus too, and when you stain them, their granules turn out, they can be bright pink or purple. All right, so that's pretty distinctive. Basophils are very rare. Basophils produce histamine. What's histamine? Anyone know? Sometimes it's allergy season, if you haven't noticed. People take antihistamines to help reduce that reaction. So what is an allergic reaction? What happens to you when you're having a reaction to something like pollen or something, or cat dander, or who knows what? What are the symptoms that you have with an allergic kind of general reaction? Someone sneezed today. That's your respiratory system trying to eject an antigen that you've breathed in that's causing irritation. Does your nose run? Do your eyes water? Do you sometimes get little blotches or something like that? That's histamine. All right. Histamine causes all of those things. Basophils are basically histamine producing white blood cells. So anytime you have allergies, it's those cells producing histamine, which cause the swelling, the heat, the fluid accumulation, the sneezing, the eyes watering, all that stuff. All right. It also causes the mucus in your airways. You expectorate, right? That's all histamine reaction. And when you take an antihistamine, it blocks the effect of these cells. So that's why I have allergic reaction. And their granules are really dark bluish or blackish staining. Now, the other two, monocytes and lymphocytes, they don't have granules. Monocytes are pretty darn rare. They are phagocytes. They seek out, engulf, or eat, because phagocytosis, which we covered back in the cell transport chapter, the cell consumes a pathogen and then breaks it down. And that's how they do it. So they engulf and destroy pathogens. The nucleus is kind of large, half, bless you, histamine, is large, half moon shaped or kidney bean shaped. And there's still a lot of cytoplasm, or the fluid component of the cell, showing. Then lymphocytes, which are pretty common just below neutrophils, the nucleus takes up almost the entire cell and you can barely see any cytoplasm. Lymphocytes, as we'll talk about in the immune system, pretty darn important. And it consists of T cells. I'm not going to define here. Don't worry about this. I'll get to it when I get to the immune system. But B cells produce antibodies. B cells produce antibodies. So if you got vaccinated for COVID, because and look how the vaccinations are working on campus. The reason that this thing isn't here anymore, not required, is because the vaccine has really done its job and the COVID cases have plummeted severely. You got a vaccination, 2 to 3 weeks later, you produce antibodies. They gave you a second shot with the Pfizer or Moderna, and then it boosted your antibodies up even higher. And then they said, well, why don't you get a third shot like a year later, which some people did, I did, just to make sure. The one shot and done, which one was that one? Johnson & Johnson? Long-term, we'll have to see how that worked out, but it worked. We produced antibodies. There are fewer people who got infected. We'll talk about the effects of COVID when we talk about the respiratory chapter, which we might get to today. We might not the end of the world. Okay, but the mnemonic for memorizing the white blood cells in order from most frequent to least frequent is never let monkeys eat bananas. Neutrophils, lymphocytes, monocytes, eosinophils, basophils. That's a classic nursing mnemonic device. All right, so you'll probably encounter that in nursing because they do deem it kind of important to know, especially in the time of COVID, which now became even more important. In microbiology, you've probably covered some of this. I mean, did you cover white blood cells and T cells and B cells in microbiology? They're very important. Those lymphocytes, those T cells, people who have AIDS is diagnosed because you have HIV, human immunodeficiency virus, and eventually maybe 10, 12 years down the road, the virus has destroyed your immune system so much, they say you've gone from HIV to AIDS. The definitive diagnosis of going from HIV to AIDS is how many T cells do you have in your bloodstream? And there's a bare minimum. And once you go below that bare minimum of T cells, they say, okay, you now have AIDS because your immune system has been so hamstrung by the virus is virtually non-functional. All right, so those white blood cells are going to be important. So a couple of white blood cell disorders, just simple ones. Leukocytosis is high white blood cell count. You suspect someone has an infection brewing, especially internally. Do a blood panel. If the white blood cells are high, oh, you've got an infection. Here's some antibiotics. And they might even do a culture to determine which antibiotics are going to be most effective for the infection that you have. So on the daily, nurses, this is something you're going to encounter. Now, leukemia is increased white blood cells, but there's a distinction. It's increasing the number of immature white blood cells, especially lymphocytes. Now, it means that your bone marrow, your spongy bone and your long bones, is pumping out white blood cells so frequently that the white blood cells don't have time to mature in that bone marrow. They're pumped out immature stages. The immature stages of white blood cells aren't very protective. It means your body's going through something, possibly bone cancer. It's an abnormal thing to be happening. Should not be seeing high numbers of immature white blood cells in the bloodstream. They should come out mature. They mature in the bone marrow. If they come out of the bone marrow before they're mature, something's wrong. Okay, so leukemia. Now, leukopenia is a decreased white blood cell count. If someone has an autoimmune disorder, and there's pretty common ones like Crohn's disease, even diabetes can be an autoimmune disorder, rheumatoid arthritis, so many things. To prevent the disease from progressing too fast, myasthenia gravis, a person can be put on immunosuppressants to slow down the immune system's attack on your own body. But the problem comes with you slow the progression of the disease, but now you don't have as many white blood cells because you're immunosuppressed. It makes you incredibly vulnerable to routine infections. That's why we were wearing masks before a lot of people were vaccinated, is if you are young and healthy, and I know some people were exposed and some people had some mild symptoms and some people didn't have any symptoms, but if you're young and healthy and your immune system is competent, it's more likely to be able to overcome that infection and you get over it. Immunosuppressed, immunocompromised people, no, that could kill them. And so we wore the masks to protect each other, but more importantly, to protect people whose immune system is not so good. All right. And young children whose immune system's not fully competent yet, and older people whose immune system has slowed down. All right, so that's why that was important. Now I'm going to cross off radiation because radiation has gotten so good in treatment for cancer that they can pinpoint that radiation to just specific area in the body without widespread radiation of the body. So that's gotten better. But chemotherapy, let me add that, can cause leukopenia. Chemotherapy, I mentioned it before. It's this cocktail of drugs they inject you with if you've got cancer, and it's non-discriminatory. It goes after rapidly dividing cells, which are cancer cells in your body, finds them. If you have any other rapidly dividing cells in your body, it's going to get them too, including red blood cells, so it can cause anemia, white blood cells, cause leukopenia. And so chemotherapy patients are told, and as nurses, you're going to be telling people if they're undergoing chemotherapy, stay home as much as possible, self-isolate, especially if there's a flu going around, okay? Because even if they got vaccinated, they're immunosuppressed from chemotherapy, their immune system's not going to respond very well. I remember my aunt went through chemotherapy for breast cancer. They said no haircuts, no manicures, pedicures, anything like that, because at the chance that a small little cut or scrape that you get with that could happen, could get infected and your immune system suppressed, and you could have a bad problem. All right, so leukopenia can be induced by treatments for other conditions. It also could be caused by cancer. Cancer could cause too many white blood cells. It can also be caused too little blood cells if the cancer is in the bone. So bone cancer's a bad thing all around. All right, so what we've got here is back to leukemia. Here is, that looks like a monocyte, that could be an eosinophil, monocyte could be a neutrophil. All right, or they could be lymphocytes. But anyway, they're white blood cells. These are white blood cells that haven't become distinctive. They don't have a distinctive nucleus or granules anymore. They're immature. A pathologist will see this and say, oh, okay, your bone marrow is pumping out white blood cells and they're not mature yet. These are not mature. These are mature because I can identify which ones they are. All right. Okay. Platelets. I asked Dory Weaver, who came to speak to you early in the semester, things that you want, I should make sure my students know. And one is clotting. So I'll do a little bit of clotting stuff. Platelets, and it's on that page in your textbook, they circulate for a finite amount of time until your body's constantly producing more in your bone marrow. They start the process of clot formation, either on the exterior of your body or in the interior of your body if something's damaged. And so here's your red blood cells, and those little pink staining things are the thrombocytes. So they produce, well, that they don't produce, but they respond to thrombopoietin. Liver and kidneys produce that. Liver and kidneys also produce erythropoietin to cause red blood cell production, but this is thrombopoietin, and that stimulates the bone marrow to make new thrombocytes. And this is happening all the time, but they don't live very long, about a week. All right. So hemostasis is stopping of bleeding. And that's what happens with clotting if the wound's not too severe. So if you have a break in the skin, let's say this is the epidermis, red blood cells, if you bleed, come out, but also there's thrombocytes in your circulatory system. They come out and they do this process to create threads that literally stitch the wound together to stop the bleeding. And then later on, that repaired site forms scar tissue. So here's what happens. If you have a broken blood vessel, and it's a small one, even small arteries have a capacity to do this, to constrict and stop blood flow. So small arterioles can clamp down, vasoconstrict to stop the bleeding. Big arteries, not so much. But what happens is when the platelets are exposed, they form an actual plug. They make the site sticky. Red blood cells form a clot, and eventually the thrombocytes form threads, which is what these things are around the red blood cells, to kind of hold everything together. So the process, quickly explained, platelets convert prothrombin, which is a precursor to thrombin. Thrombin activates fibrinogen. Fibrinogen creates the threads that literally stitch the wound together. And it's very complicated. There's a whole long list of clotting factors involved. You'll find out about people who have clotting disorders. But it literally looks like this. Here's red blood cells, clumping of a bunch of platelets, the purple things, and all the thrombin threads are the green things. And it's literally holding everything together, forming a plug to stop the bleeding. And eventually you have cells which will come in and put down scar tissue. All right. So there's a clinical, well, you know what? I'm not so worried about this. Let me see what it includes. There might be something important, but I think it might be too much. How about this? Hemophilia, which is something that can happen, and it is genetic. All right. We have 12 or 13 clotting factors. There's a lot of them. You might learn some of them in nursing. But if you have a defective clotting factor, you can't form these fibrin threads. And people who have hemophilia, if you get a small cut, you're prone, it'll keep bleeding and bleeding and bleeding. People who have diabetes are also at this risk. I'm not going to get into that, but if you get a small cut, it doesn't want to heal very well. So hemophilia, just know that is a disorder of the clotting mechanism. I'm not going to get into the clotting agents and anti-clotting agents. That's a little bit too much for this physiology course, but you will learn more of it in nursing because it is important. Okay. So how do you know if someone has a clotting disorder? A quick test that a nurse can do right there in the office. So you can simply, okay, so you guys lanced your finger with the lancet to get some blood to do the blood typing. Did it keep bleeding for 5-10 minutes after, did it? No, probably a minute or two. It stopped because some of you, it took you a long time to get enough blood, and all of a sudden, I'm squeezing, but no more blood's coming out. It's because it's already clotted. It's already healed. Fibrin threads have put down to stop the bleeding. If someone bleeds after being stuck with the lancet needle like you do in lab, 3 minutes or later, it's still coming out, still coming out. That's not normal, okay? It's supposed to stop within a minute or two, unless it's a big needle. We use a 28 gauge lancet, all right? If you get stuck with a 12 gauge needle, I expect it to bleed for a while because it's gonna be a big needle. But the ones you're using, if you bleed for more than 3 minutes, that's not supposed to happen. Another thing you can do is look at prothrombin time. This is a little bit more involved. You draw some blood, you centrifuge it down, you get the liquid portion of that blood called the plasma, and you treat it with citrate and thromblastin, add calcium, told you it's a little involved, then measure the time it takes for a clot to form. All right. If it's less than 10, 12 seconds, you're okay. If it takes longer, clotting disorder. Why would you need to know this? Let's say someone has to go into surgery. All right. And they kind of have extended bleeding times. Do you think that's a safe person to undergo a surgical procedure if they bleed and bleed and bleed? No. This is why people who are on blood thinners, because of problems, they're at risk for stroke. Before surgery, they have to stop the blood thinners. My dad had this. He had to undergo balloon angioplasty, but he was on blood thinners because he had some cardiovascular issues going on. And they told him there is a chance because you were taking off blood thinners and now you have to go through this surgery, the balloon angioplasty, that you could form a clot and then you could have an ischemic event. All right, so I'm just introducing the idea to you guys. Thrombocytes cause a clot to form because they produce the threads. Sometimes people have clotting disorders where they don't form the clot and they bleed, and you can test it with this. And then you're going to encounter patients that might be on blood thinners that prevent this process from happening. So you'll kind of be exposed to the whole process of blood clotting versus being on blood thinners. Okay, and this is the last slide for this chapter. Another brief introduction to what you would do on the routine as nurses is collect blood. All right. So vacutainer tubes and needles. A vacutainer is for vacuum. The tube will have a vacuum. It's a glass tube that has a rubber stopper in it, and it's got a vacuum inside. The air has been withdrawn from that tube. And so what happens is you have a vacutainer needle with a little plastic hub. Person's got a little tourniquet on their arm. You're looking for that vein. Get good at hitting those veins. All right. And then when you put it into the vein and blood starts to drip into here, you know you're in the vein. And then you pop on the vacutainer tube and the vacuum sucks in the blood and the tube fills very quickly. Like full, next tube, full, next tube. You can draw blood very quickly. All right. So you're going to learn to do that very effectively. Each tube has a different thing in it for a different purpose. Red top tubes, most very common. It has no anticoagulant. So what will happen is if you let that tube sit in the fridge or whatever, the heavy things like red blood cells will sink to the bottom, white blood cells kind of be in the middle, and the liquid portion of your blood, the plasma, will float to the top. And that's it. If you use a purple top tube, it has an anticoagulant in it called EDTA, and I don't remember what it stands for. It's a long word. And what will happen is it will keep it from clotting, basically. So even if you sit it in the fridge over like an hour or so, the red blood cells will go to the bottom, the liquid portion will go to the top. But if you take the tube out and do this, it all mixes in together again. So that's whole blood. If you have a panel that you need whole blood for, that's the tube you use. And you can spin it and the liquid portion will rise to the top, and you can pull that off if you want. When I was a vet tech, I used to use these tubes and I would pull out, I'd use whole blood for heartworm testing. All right, so I'd use these tubes, not that, because I want the whole blood. Light blue has an anticoagulant known as sodium citrate, and that is the one you use for those clotting tests I was just telling you about. And you're going to learn all the other ones, and they all have their purpose. All right. And so I'm not going to go over this here, but if you're curious about this, I've got the Wikipedia page where it talks about all the different tubes and what they're used for and things like that. But that ends cardiovascular system. Yay. It was a big chapter, but it was an important one. All right. Now, I got a little bit of time. I'm going to jump into the respiratory chapter because I kind of want to start that. All right. So I'll post these notes today as they're finished. And then we'll be going over the next chapter, which is the respiratory system. And when COVID hit, this was such a cool topic because everyone's so interested in it. Now, I don't know if you care about COVID or not, but it's still out there. Can't forget about it. I know you covered respiratory system and anatomy. Okay, we had those good models. So we're going to do a quick review of respiratory anatomy, but I'm going to take it a little bit further and explain some things that you're going to see as nurses with the respiratory system. So, vocabulary. You've learned these things, but I don't know if you've learned the categorization of them. So the conduction zone and respiratory zone are two different zones of the respiratory system. If you conduct something, you're getting it from point A to point B. In the respiratory system, you're taking atmospheric air out here, point A, to inside your lungs, inside your alveolar sacs. That's point B. So the conduction zone is how do you get atmospheric air into your alveolar sacs? Basically, just a little bit before your alveolar sacs. So that includes your pharynx, which is the combined nasal and oral cavities, the pharynx, right? And then the larynx is the voice box. Air moves across that, and you have muscles to control it to make these wonderful sounds that you can do. Then it goes to your trachea, all right? And you can feel that trachea and the cartilage rings that cross it. And then the trachea bifurcates into different bronchi. So the primary bronchi are the first branches off the trachea, and then those first branches break off into secondary bronchi. So if I were to do this, here's the primary. Oh, that's a terrible color. You can't see that. So this branches off to primary, then the primary branch off to secondary, then the secondary branch off to tertiary, and then tertiary branch off into terminal bronchioles. And those are going to attach to the respiratory zone. Okay. So when you take air in, we don't think about it now, but when it was cold out, when we had those 19-degree, 20-degree days, you breathed in the air and it kind of hurt. I come from the North Country, upstate New York, close to Canada. We had times where it was minus 40-degree wind chill. You have to wear a scarf or a mask, because if you breathe that air in as cold as it is, it will destroy your alveolar sacs. All right. We don't have that kind of temperature here, but your conduction zone warms and humidifies the air that you breathe in from the atmosphere before it gets down to the alveolar sacs. Why is that important? I'm going to show you. The alveolar sacs are very thin. Those are the ones that look like the little grape clusters in the lungs. They're one cell layer thick. That helps conduction of air across the membrane. So if it's a thin membrane, gases can cross by diffusion, simple diffusion, no problem. But being so thin, those airways, those alveolar sacs, those membranes are prone to damage. COVID inflames the sacs. They're one cell layer thick. They get damaged. All right. Have you heard of long COVID? Where COVID has caused so much inflammation because people who have it and they don't get over it in a couple of weeks, that persists with them for months and months and months. Those alveolar sacs are chronically inflamed. They put down scar tissue, and now oxygen and CO2 don't want to pass across that scar tissue. They've got long COVID. They've got permanent lung damage. All right. So is all this stuff relevant to nursing? Yeah. All right. Okay. So you have cilia in your airway, especially your upper airway, not so much your lower airway, that if something is inhaled, that's an antigen that you're having a reaction to, you can expectorate that mucus. I'm not really producing mucus, I'm faking it. And bring it up into your mouth. If you're outside, you can spit it. But if you're inside, what do you do with it? Swallow it, goes down to your stomach, where stomach acid kills it. All right. So all that is important. All right. And this over here is the damage that cigarette smoking long-term causes to the cilia. Notice they're not there anymore. So expectoration is just this thing I was doing. It's normal. You do it all the time. Okay. Now, anatomy review. As you take air in from your nasal cavity up here in your oral cavity, it meets in the pharynx. It comes down here. You've got two tubes. The anterior tube to the front is your trachea. That's the air tube. Posterior to that is the esophagus, not shown here. When you swallow, you have pharyngeal muscles that compress this pharynx to cause the epiglottis, which you probably might be able to see very well right here, and causes it to close over the glottis, which is the opening to the trachea, and to protect it so that food and liquid go down the esophagus, not into the airway. Okay, so I think I have a little GIF for that. Swallowing, epiglottis folds over the airway, food goes down the esophagus, not into the airway. There are conditions that can cause this autonomic smooth muscle response to become sluggish. I know someone who died of it. I just visited a wife whose husband died from asphyxiation from oculopharyngeal muscular dystrophy. He had basically a muscle weakening disorder, and it goes after the eye muscles, causing drooping. It goes after all your muscles eventually, but it goes after the pharyngeal muscles and makes those muscles sluggish. And so the epiglottis doesn't time itself right to close over your airway. He was eating, he aspirated what he was eating, and he died. Okay. And that can happen to people with myasthenia gravis, where acetylcholine receptors are destroyed. They have to eat and swallow very carefully because it can go after muscles like this. So is this important in nursing? Kind of. Okay. So that should be anatomy review. Now, your respiratory zone simply starts right here. The tiny little respiratory bronchioles right here that attach to the cluster of alveolar sacs. That's the respiratory zone, because that's where gas exchange is going to occur. So we have so many alveolar sacs in our lungs that if you looked at the surface area of those alveolar sacs, it'd be like a tiny home, okay? 760 square feet. That's surface area to allow gas exchange. So that's why we have so many of them. Now, if we look at those in cross section, cut them open right here. See the little hole? Right there, right there, right there, so on and so forth. That's where the air is coming in from those respiratory bronchioles, and that air fills the sac. And when the air comes in, when you inhale, the sacs could do this. They fill up, and then when you exhale, they do this. So breathing in, breathing out, breathing in, breathing out. Okay. So the blood vessels, pulmonary arteries, pulmonary veins. Okay. It's colored blue because it's carrying oxygen poor blood. It's colored red because it's carrying oxygen rich blood. This vessel came from the pulmonary trunk of the heart, and it became left and right pulmonary arteries going away from the heart. My question, well, I've already told you, if it's traveling away from the heart to the lungs, it's a pulmonary artery. Arteries always go away from the heart, but it's carrying oxygen poor blood. That's why the color is blue. This is returning to the heart with oxygen rich blood, but it's a pulmonary vein. So in anatomy, I hope you got that. Some of you are, I told, we're just starting the cardiovascular system. So I've already given you a little info for that. Now, pulmonary arteries wrap around those alveolar sacs, as do the pulmonary veins. And what's happening is those pulmonary arteries are carrying high CO2, low oxygen. And it's called a capillary plexus, where it goes around these sacs. The oxygen that was taken in with your breath, inhalation, all that oxygen then diffuses, simple diffusion, into the pulmonary veins, which are now oxygen rich, and go back to the left side of your heart. So remember how I said diffusion? Things are lazy. They always want to go from high to low because it's easy. Gas moves the same way. Simple diffusion, but it's based on pressure of the gases. So where oxygen is in high pressure, it's going to want to go from high to low. So it wants to go from where it's low to where it's high in the sac. It's high here. It wants to go from high here to in this blood vessel where it's low, and then it goes back to the heart. So it's the same concept, high to low. Let's see our time here. Okay, we got time for one more slide. So notice this is the pulmonary vein. This is the pulmonary artery. And what we have here is high oxygen and low CO2. So I'll make it small. Oxygen is going to be high in pressure inside the sac after it expands with the breath. And that oxygen is going to want to go from high to where it's low in the vessel, and then it becomes the pulmonary vein, goes back to the heart. The CO2 in here in the pulmonary artery is high, and it's low in the sac. So CO2 diffuses from where it's high in the pulmonary artery to where it's low inside the sac. And now the CO2 is now in the sac. And when you next exhale, the CO2 goes out and it's gone. Bye-bye. But the only thing I want to impress upon you is how thin right here. See, this is a cell nucleus. This is the thickness of the sac right there. That's it, that little yellow line. Great for gas exchange. Very vulnerable to damage. So when you think about flu season is going to be coming up in the fall, there's going to be vaccines for that, pneumonia. If you're a chronic smoker or vapor, the things you're taking in are foreign antigens. Those antigens don't belong in your body. What your airways do is you have an inflammatory reaction involving histamine. It causes swelling. It causes fluid accumulation. And if you do it over a long-term period of time, or let's say it's a COVID virus, and it's causing inflammation over a long period of time, guess what? There's going to be formation of scar tissue. It swells, fluid builds up, and now you got fluid in your airway. What happens in a warm, humid environment? Do bacteria like that? Yeah. So if you've got a lot of fluid accumulation in warm, humid lungs, guess what? You're setting yourself up for a bacterial infection in your lungs. And if it happens for a long enough period of time, few years, scar tissue, guess what? Oxygen, CO2 don't want to diffuse across that scar tissue very well. So I'll set the stage and I'll talk about the rest of it after the quiz on Friday.